Hello, this is season 2, episode 11 of the Six Lessons podcast. Today's topic is endodontically treated teeth. Endodontically treated teeth were not originally part of the Six Lessons approach to advanced adhesive dentistry. But obviously, every dentist that is fixing vital teeth eventually has to fix some non vital teeth. The traditional approach has always been full coverage, and many full coverage crowns that have had endodontically treated roots have failed. And I saw that very graphically in the first 17 years of my practice. Led me to quit dentistry for 6 months, and then I became enthusiastic about the opportunities or the chances of a prevention of root canals and a prevention of crowns through advanced adhesive dental techniques. And so the first concepts that we approached for vital teeth turned out to be the best concepts also on non-vital teeth, but non-vital teeth have one huge disadvantage. The structure of a tooth is functioning best when it's hydrated. The hydration of the tooth comes from the pulp. If the pulp is missing, the hydration of the tooth is decreased by about 60%. There is some hydration that is coming actually from the PDL and helps the tooth have some flexibility. But the important article that was definitive in establishing the difference between vital and non-vital teeth in a restorative context was published in 2007 by Kishen and Vedantam. In 2007, we had already been teaching the 6 lessons approach to practicing dentists for 4 years. But when Kishen and Vedantam came out, and it was obvious as we talked to more dentists and taught more dentists that preventing endo is great and preventing crowns is great, but if a tooth already has a crown or already has endodontic treatment, what do we do in those situations? Do we still rely on mechanical posts, buildups, retention forms, ferrule development, all of these classic prosthodontic techniques that had been tried and implemented for almost 100 years, still had failures? And so the question is, could you reduce the number of failures that were catastrophic, or could you increase some of the failures that might allow a repair? And as we applied the principles of the 6 lessons to endodontically treated teeth, it became obvious that the answers to those questions were yes. We can decrease the number and the severity of the failures. In the 6 lessons approach, we always start by an analysis of our failures. That's how I decided to not quit dentistry. I felt like the failures could be changed. And the 3 types of failures that have been identified in the literature are clinical failures, where there's a chip of the outside or the restorative material, the outside of the tooth, enamel mostly, or a crown or an onlay or a composite restoration. If there is a chip to the tooth and the patient can feel it with their tongue, we call that a clinical failure because the patient's aware that something's there. They feel it with their tongue. They come to the dentist, say something is broken. Quite often, those clinical failures are added to a biologic failure which has preceded the actual fracture. And so a biologic failure would be there is a gap or a crack underneath the restoration or into dentin that is infected. And this leads to crack propagation and reinfection or redecay. And so this biologic failure, if we can find that early, then we're able to treat that before a lot of damage through fracture decay is happening. And so we have a risk assessment that we've taught in lesson 2 from day 1 in the 6 lessons approach. And it was one that I developed to help me make an analysis on teeth that were asymptomatic. In other words, if a patient comes in and a part of your tooth or part of the restoration is broken off in their hand, obviously it is fractured. But what was that like before the tooth or the restoration broke off? Well, there was some type of crack or gap allowing reinfection or a crack propagation. And so once they understood that, we made a risk assessment. And the risk assessment was based on the remaining tooth structure that was present. Now, the remaining tooth structure in a vital tooth always includes a pulp. But in a non-vital tooth, this risk assessment is actually even more important because we know from many traditional studies that teeth that have had root canal treatment but do not have full coverage protection of the cusps are more likely to fracture early. Now, that goes halfway up the hill of trying to figure out how to prevent these catastrophic fractures, which would go into the root, from happening. And so this Kishen of Vedantam says you're 3 times as more likely to have a brittle root and a fracture in a root in a non-vital tooth as a vital tooth. But if we do have the ability to stop a fracture coronally before it gets to the root, we can have a great success in restoring these teeth without crowns, which again removes vital part of the tooth structure that we've identified and named as the biorim. And the naming of the biorim, identification of that, came initially from a finite elemental analysis study that was done by Belser and Pascal Magne 2002. Once that was identified with this finite elemental analysis, it showed that under occlusal function, unless you have an idealized vertical function, you have a tremendous stress concentration in the cervical 2 to 3 millimeters of the tooth. That's the part of the tooth that's under the hydrocontour. And so in the 6 lessons approach, we've always taught that the critical tooth structure is below the hydrocontour. The non-critical tooth structure that could fracture without causing a biologic or a catastrophic failure is the top part of the tooth, or the 3 millimeters on top. If you have a short molar, it's about 6 millimeters. If you have a taller molar, it's about 7, sometimes an 8 millimeter coronal portion of the tooth from the CEJ to the marginal ridge, but someplace between 8 millimeters and 6 millimeters. We have 3 millimeters that is critical below the hydrocontour, and then 3 millimeters non-critical on the top above the hydrocontour. And those teeth are quite often the cusp are onlaid, or in extreme situations of crack propagation, we have preparation that would be an overlay preparation. But again, the onlaying of tooth structure in the 6 lessons approach, the primary reason for that is visualization of decay that's being identified with caries detecting dye, and the removal of cracks, which is being identified with dehydration or application of self-etching primers, which help the cracks be visualized. So once we have the idea of we're onlaying for visualization, this also is what we do in a non-vital tooth. So in a non-vital tooth, if we have pulp that's dead, obviously we have a different approach in part of the dissection of deep decay and deep cracks. We approach the dissection of cracks and the removal of caries differently in a vital tooth versus a non-vital tooth. In lesson 1, we've talked about how we create a peripheral seal zone that's inside the DEJ, and we work carefully towards the central stop zone, which is a millimeter around the pulp, and we stop there because we don't want to expose the pulp. Exposing the pulp triples the chance that the inflammatory response will be fatal to the pulp. And so in a non-vital tooth, the excavation of decay and cracks can come, instead of the outside in, it can come from the inside out, because we're not worried about the pulp dying. It's already been extirpated, it's gone. But we can look at a crack inside a pulp chamber, and we can dissect that crack inside a pulp chamber. The same with decay. Deep decay would be completely removed instead of partially removed, as the 6 lessons approach on vital teeth would recommend. And so once we have this caries removal endpoint in a non-vital tooth and a crack removal endpoint in a non-vital tooth, quite often it will be going down into the root deeply. And that deep dissection of cracks and decay on a root from the inside out would stop by measurement at the PDL, or a little bit before the PDL, to help establish a blood-free isolation. And these are all advanced techniques. These are all techniques that Davey has been the greatest pioneer of, the copper band inside the stainless steel matrix for isolating these teeth that are basically cracked to the level of the alveolar bone. And these 9, 10, 11 millimeter dissections of decay and cracks, and then the isolation of those dissection becomes helped if part of the root can be preserved, even though it has a small crack. It separates the restorative process from the PDL, and it allows the band, which in the situation of the double band technique is a stainless steel band that's stabilizing the copper matrix band that is pushed down with force to do a blunt dissection. But if you have a little lip at the bottom or even a lip of 2 millimeters on a 10 millimeter dissection. It gives you a sure lip to hold your matricing, and it's an advantage in these very deep situations. And of course, situations where you're restoring teeth, they have such a variety, but basically, the longer a crack is left in a tooth, the longer it gets. And these dissection of these deep cracks under the root, in every other system of restorative dentistry, these teeth are condemned as unrestorable. Unfortunately, for the people that teach that, they haven't been trained in the 6 lessons and they haven't restored some of these unrestorable teeth. Now, if you have an unrestorable tooth by somebody else's criteria, and you save that tooth for 2 years, 4 years, 6 years, 8 years, 9, 10 years, 20 years, the definition of unrestorable has to be based on how long the patient lives, because many of these restorations that we've performed have been permanent on patients that were restored when they're 60 or 70 and they died when they were 80 or 90. Once a tooth is taken out, then the patient is usually left with the idea of having no restoration, which is an option. If you have 28 teeth and you lose one, that means you have 27 teeth. Can a person live to be 100 with 27 teeth? Absolutely. But can they live with 26 or 25 or 24 or 22 or 23 or 20? In Japan, there is a program in the national health system for dentistry, is that they know that the quality of life is limited if the patient has less than 20 teeth. And so in Japan, the standard for the national health insurance for the dentistry, the program is 20/80, or maybe it's 80/20. But the idea is that by the time the patient's 80, if they have 20 teeth, then we will consider this successful dental treatment, not impacting the quality of life. Aesthetics in Japan isn't a big deal. If they're missing a few front teeth, it might not be a big deal if they have a fractured front tooth. I mean, all of these give a broad ability to create your diagnosis based on what you want that patient to have, and that should have input from the patient. Ask the patient, are you okay losing 8 posterior teeth? If you are, well, then you can lose 4 on one side and 4 on another side, and you still have your bicuspids and all these. You look good. You can still chew with bicuspids. I mean, these are all real practical considerations that worldwide, different countries and different cultures have approached in different ways. But in the United States, where usually we have options of doing a root canal versus doing an implant or doing nothing because the patient has sufficient teeth for their goals of how they look and how they function, then we just have these discussions with the patient and we say, you've lost some teeth. These teeth can be saved that you have. Are you interested in doing that? It's your choice. It's your body. And most patients, pretty much 100% of the patients have been coming to my office for the last 25 years, maybe longer, have always said, I'm coming here because I want to save my teeth. And maybe they have a grandmother that didn't like her dentures or a parent that's had problems with tooth loss. But if a dentist has confidence that what they're doing is going to preserve that tooth as long as possible, the vital tooth is the one you can pretty much guarantee. If you have 50% of your biorim and you restore it with a stress-reduced direct or a stress-reduced indirect technique, with the biobase being indirectly bonded in that 30 to 50 megapascal range, then you can just tell the patient, we've done 1,000,000 of these teeth in our network, including all the doctors that I've trained, and these 1,000,000 teeth have such a success rate, we basically say we can guarantee this tooth to be in your head for life. That statement is not applicable in teeth that have already had endo or teeth that have cracks that aren't fully dissected. We've had many cases that we've treated over the last 25 years of teeth with cracks into their roots, using the principles of 6 lessons for adhesion and lesson 2 for dissection. Then we have the ability to say, this tooth that has a crack into your root may not be a permanent restoration. And that's the best thing to say. How long is it going to last? We didn't really have good numbers. I think we have enough numbers in our network now to say that if you have a crack in a root that cannot be completely dissected because it is, let's say, mid-root, that we have dissected enough of these teeth and restored them with the wallpapering technique that will be our topic in our next episode. But we have enough experience with these teeth to say, in these hopeless cases, we still can guarantee 5 years. But in reality, the teeth I have, I would say I can pretty much guarantee you'll have 10 years. But we have lost several teeth at that 10-year mark where eventually the mid-root crack has gone apically, and now we have a periodontal condition that's taking out some buccal bone, for example, in a fistula or an abscess, and be better to remove that to limit that bone loss. And if a patient wants to do an implant, that's important, that helps. But most of the patients that I've treated that are in their 70s and then they get to their 80s, if they lose one tooth, one more tooth, it's not the end of the world. But it's been explained to them when we first treated that this tooth is at risk of being lost. And it's at risk of being lost to a much greater chance if the tooth had not had a root canal. And the patients, they've come to our office because the only option they were given was extraction and implant. And so they've come to our office from different states looking for an option. And we say we understand that most dentists think these are hopeless, and they may be hopeless for the rest of your mortal existence, but you don't know how long you're going to live. But if you lose this tooth and you're 80 years old, it might be different than if you lost another tooth, for example, a front tooth. But fortunately, the front teeth have less forces of occlusion. They have about a tenth of the forces of occlusion that back teeth. So all of the teeth that I have lost with this, what we call lesson 7 approach, where we apply the 6 lessons approach to endodontically treated teeth, all of the teeth that we have lost, which in my case have been 4 teeth in over 20 years, those have all been posterior teeth where the forces of occlusion can be up to 200 pounds per square inch, where anteriorly we have maybe 20 pounds per square inch because you don't chew normally on the front teeth. Now, if a person has lost back teeth, then that changes and forces get higher on the front teeth. But in the 6 lessons approach with the wallpapering technique, which will be our next topic, we've had one restoration that did fail, but it failed clinically, meaning the restoration of the root that had cracks and deep decay anteriorly, when it was rebuilt with 2 fail-safe systems. And the 6 lessons has been using these since 2003. The first fail-safe system was a resin coating of microfill flowable. That was demonstrated in 2003 by Jayasuriya and Tagami and his research there, is in vitro study. But then we also, the next year, 2004, we had studies that showed a fail-safe can be built underneath an enamel replacement by placing rib-on. And this was done by Willem Fennis and his team, Quees, other researchers at Nijmegen University in Holland. But these 2 systems of a microfilled or a nanofilled hybrid layer being protected by this resin coating, and then the fiber rib-on being placed as a added fail-safe, secures the bond to the remaining dentin that you're bonding to. And if you did have a failure of under function, you would have a failure on the top half or non-critical portion of the tooth. And this has happened once in our office. It was while a patient, he had lost all of his posterior teeth, was having implants, and he had his anterior teeth that are now starting to fail, and he wanted to save his anterior teeth from extraction and implants. Anyway, we restored one tooth, and it was 6 years later he had a failure of the enamel replacement, and we were able to repair that. And now, a couple of years later, he's into 8 years with this lesson 7 restoration using the 6 lessons approaches. And he's very happy that he's saving his front teeth. And I think he's happy with the implants he's had in the back teeth. And he's 77 years old now. And, it's like when he's only 70 years old, he was thinking differently than when he's 77. And I'm 73, and I'm thinking much differently than when I was 63. But personally, I have lost one tooth from a vertical fracture that was not diagnosed. I think I mentioned that in an earlier podcast. And I've chosen not to have that replaced with an implant. I chew fine. I look okay. It's like it doesn't bother me. Another patient would have different feelings about replacing a missing tooth. But all of these questions and the difference between a vital tooth, a non-vital tooth, I believe that's foundational before you start learning the techniques to reconstruct an endodontically treated teeth and then giving the patient that option. But most patients, they will still say, implant's going to cost me $3,000. A restoration is going to cost me $1,200. I still have a little bit of money. If I have a failure that can be repaired, I'm still coming out ahead economically. But in reality, the idea is that what you want to do is you want to do the thing that restores a tooth that doesn't damage an adjacent tooth. And a missing tooth, traditionally, way before implants were viable. When I graduated in 1978, implants were still not long term. They would almost all fail at 3 years in 1978. That's changed a lot over the next 4.5 decades. But implants are relatively expensive compared to what we do with offering the reconstruction of endodontically treated teeth. But again, I want to emphasize that the vast majority of teeth that are non-vital and that are restored without crowns and using the wallpapering technique of the 6 lessons are doing just fine. And we have hundreds of thousands of teeth that have been restored by dentists who have been trained by master teachers of the 6 lessons approach from around the world. We see very high patient satisfaction, particularly in countries where implants are a little prohibitive as far as the expense to the patient. An adhesive restoration can be done for a fraction of the cost. And now we're seeing, in my opinion, at least an equal survival rate as implants, because implants don't have 100% survival rate. In some studies, we've had 20% failures of implants. And of course, it is operator dependent. Operator variability is a big part of the 6 lessons. We have a standardized protocol, a very specific set of protocols that need to be done to ensure that we maximize the bond strength by minimizing the stress to the hybrid layer. And so that's called the adhesive equation. That's been a fundamental principle that I learned from my second mentor, Gary Unterbrink, in 1998. But all of these variabilities, if the person who's doing it doesn't do it right, is like anything else. But it is something that needs discipline and it needs practice. And the more you practice, the more subconscious and automatic it becomes. And that's the definition of mastering biomimetic restorative dentistry. So with that, we're going to sign off. And next podcast will be our 12th of the season. I believe our last of our season 2. So I've enjoyed doing this. And we've had a lot of good feedback. And we had a lot of people coming into the mastership after they have their interest piqued or they have some more in-depth questions they'd like answered. And we invite all of you to take advantage of the hands-on and the online Zoom instructions that we give. With that, we'll sign off. Get bonded, stay bonded. Till next time.